Welcome to the CodeCast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the CodeCast podcast today. My name is Terry Fletcher. So today is our 183rd episode of the CodeCast. And before we begin and I dive into my topic, I just wanted to update everyone that last Friday, April 16th, the PHE, the public health emergency, was extended another 90 days. This takes us through July 20th, 2021. There was a little bit of a discussion whether they were going to extend it at all. I know that the current administration was saying that their plan is to extend it through the end of the year, but because we're seeing such a decline in the hospitalizations and in positive cases in most states, there was a little bit of discussion, I should say a lot, on if they were going to extend it even another 90 days. But they did, which I absolutely anticipated. Nothing like waiting till the last minute, though. So it was at 4:30 p.m. on Pacific Standard Time, California time, on Friday that they let us know, which it was supposed to expire on Tuesday. So you have at least 90 more days of working under the CARES Act flexibilities. Also, more good news. On Thursday, they announced, again, CMS announced that the sequestration reduction, so the sequester reduction of 2% that we usually see on Medicare claims, I mentioned this last week, that the Senate passed March 30th to suspend through 2021. Because remember, with the pandemic, they suspended it last year, and it was supposed to start again on April 1st. The House came back from their spring break, and they did pass it. And so now your Medicare claims will be released without that reduction through the end of the year. And that was a good thing. Just keep an eye on one thing if you can, and that is the fact that the last spending bill, the $1.9 trillion, they call it the rescue plan. Not sure why, but that plan basically is supposed to increase that sequester reduction to 4% starting in 2022. So just keep an eye on that, because a lot of times they don't tell us, and all of a sudden we look at our Medicare EOBs, and what the explanation of benefits tells us the check should be has a percentage reduction on the actual payment, and you have to be mindful of that's what that's for. So just be aware of that. Also, again, for those of you that got the advance payment from Medicare, that's starting to offset your check as well. I mentioned that last week. Okay, so now that we've gotten rid of the most recent Medicare alerts out of the way, now I want to talk about coding a bit. And what I've had is some interesting coding questions this week from clients that I thought I would share because they relate to the 2021 new E&M service guidelines for the office visit. And just when you think you've heard of everything, think again, you really haven't. And I do appreciate my Coding Coder clients because they really make me research information and think outside the box when we're trying to just feel like we've answered every question for you and brought you just as much information as we can to clarify things. Something else comes up, and it's usually something the doctor brings to their staff, and then you guys bring it to me. But first, the CodeCast is also brought to you by JP Morgan Private Bank. Connect with over 200 years of experience, service, and stability. JP Morgan Securities, JP Morgan Chase Bank, privatebank.jpmorgan.com. Okay, so let's take a look here. I wanted to shout out Sydney and Jan from Memorial Health System. So they're a Coding Corner client that sent me some great questions this week. So here is a good one. This one, and I can understand why they asked the question. So this one basically is about B12 injections. And the question was, it said, Terry, good morning. It says, I have a quick question for you today. When discussing prescription drug management, we had a question come up regarding injections and immunizations. If during a visit, the patient's chronic B12 deficiency was addressed, and it was determined that the B12 shots that had previously been prescribed are necessary and the B12 is given in the office, can we count this as prescription drug management? We are also billing for the administration of the injection. How about when a patient has a migraine and the provider prescribes a Toradol injection that is given in the office and we charge the administration for the medication? And just to clarify, we would not be able to count these as orders in the data point section because we are separately reporting these services, and they're really not tests either. Also, a second question was as far as regular immunizations, so flu shots, tetanus shots, and things like that. Would you be able to count these as prescription drug management? So my response to this was, because Medicare talked about this in an office hours call, and then they put it on some of their clarification worksheets on the new rules for the office visits. So because so many PCPs give vaccines and preventative test referrals, and they want credit for that in the data points and in medical decision making. But Medicare said that if it was in the preventative category and not a prescription to treat or manage the presenting problem addressed, then it cannot be considered in the medical decision making for the patient encounter. So even though B12 seems to be preventative, that could be a consideration there as far as not being able to bill for it. But I actually came back and responded again to that. So let me hold that thought for a second. But the migraine medicine is to manage the patient's migraine headaches. And so, yes, I would put that in the moderate risk of prescription drug management. And none of this would I include in a data point because, again, it's not a test. It is actually a treatment in the form of how to manage a patient. So you would not include that in your data points. But here's what I came back with. And actually, I did some more research on this. And this is why I wanted to respond back to them on the B12 shot. So B12 supplements and food fortified with the vitamin are readily available to anybody, but vitamin B12 shots are only available by prescription. So a clinical diagnosis is always necessary to be able to bill for these services. So in saying that, I would actually put that under the prescription drug management option under moderate in the risk and management of a patient on the E&M rules. So now if you're trying to level the code based on time, I would not use the time that it took to perform the injection under the total time of that visit, because again, we are, or you're billing for that injection administration of that service. So hopefully that was a way to explain that one. Now, what about, and some of you are dealing with this and probably haven't even thought about it, what about pre-ops? And so this was a great question, again, from the same client. And I just really appreciated this question because it made me think. It said we've been bombarded with preoperative visit questions by our providers and their family practice internal medicine. So they're having trouble where to put this under as far as number and complexity of problems. Now, their MAC carrier said the problem is in the pre-op clearance, not per se the reason for the surgery, even though they understand that the columns can come into play, but they asked an opinion, where would you consider putting this? So my response back to that was, because I thought this was such an interesting question, I would actually put this under acute illness with systemic symptoms or undiagnosed new problem, which again falls under moderate, because not all patients need a formal pre-op referral. So they must have something that would warrant a clearance, not just an administrative pre-op, if you will, the H&P paperwork that the hospital requires, so that they can have their surgery. So I would include the surgical diagnosis as a secondary reason, but the primary, in my professional opinion, would be the reason for the potential morbidity on the patient. So the risk, if the patient did not have the surgery, that's what the clearance is for, is to determine, are they surgery ready and what is their overall risk? Because I audit a lot of records when it comes to pre-ops, and in the medical decision making, a lot of times the physician will say, that's doing the pre-op clearance, will say this patient, until they get their screening stress test or until we send them off for an echo, they may not be able to have the surgery. Or there could be some effects of the current medications they're on that could counteract or have a toxic effect against the anesthesia that's being used. So anyway, these are great questions, but something you may not have considered when you're auditing a chart or self-auditing. So keep those in mind, because just when I think about some of these questions, I think those are going to come up for you, especially on the E&M services. Now, here's another question that came up, and you can tell I really wanted to focus on some coding today. So it's called the CodeCast. I know I've been doing a lot of just giving you a lot of the Medicare updates, and it's amazing how many we've had over the last 3 months, the first quarter. But I wanted to get back to some coding information because I just feel like it's still it should be part of what we're doing with the CodeCast. So hopefully you're appreciating my pivot back to the core of what we're supposed to be doing here. So this comes from a client in Chicago. Thank you, Shar. It says, I received this question today, and the more I think about it, would this be acceptable to bill the e-visit codes prior to COVID? If the physician communicated through the MyChart portal, the physician could not bill for it, correct? That is correct. Remember, under the flexibilities, and now we've got 3 months more of it, physicians are allowed to bill certain services. And again, the biggest thing you have to keep in mind is it's to slow the spread or to keep of COVID, or to keep vulnerable populations from, again, not contracting the virus. And so you have to make sure that that's part of that discussion. But here's something that the providers were asking. They're inquiring if they're able to bill for the MyChart visits because they have times where patients want to have extensive communications back and forth for disease management. So yes, again, those have to be patient initiated. The codes you're looking at are 99421 to 99423. Make sure that the patients know they are still subject to copays and deductibles, because a lot of times patients don't realize if they email the physician through the portal site that they're going to have to still pay an out-of-pocket. That's actually medical care that's going back and forth. But the biggest thing to remember about these visits, and they're called the digital e-visits, is that they're based on time and they're cumulative. So it's the physicians are going to have to, I call them docs, the docs are going to have to keep charted time during a 7-day period because it's cumulative over a 7-day period, and then add that time together for that 7-day period, and then pick the code based on that time period. So it's not every single time the patient sends over an email or an inquiry, and every time the doctor responds. It's based on time, based on that 7-day period. And you really want to, I don't want to say limit patients, but monitor patients that are excessive with it so that they don't, kind of go crazy and think that they can just once a day send over questions. So it's really for, medically indicated, medically pertinent questions and kind of troubleshooting things they don't understand about their healthcare. And some patients are still at home, and I would hate to say bored, but they're looking for something to do. And if they've got access and they think it's free access 24/7 to your physician or your provider, you're going to need to put some safeguards on that and just some, understanding as far as boundaries, I guess the word is, on how often that's allowed to be used. So just be aware of that there's not only time constraints on that, but it's cumulative time, and it has to be patient initiated. So yes, those are available now, and there has to be a tie-in on why you're using that. Now, once COVID ends, or I shouldn't say once COVID ends, once the public health emergency ends, you're going to have to figure out which payer is going to cover it. Medicare probably won't, since they're also rolling back after the PHE ends phone calls. So, and they're not going to pay the same parity with office visits, and there's going to be some place of service issues there, but we'll get to that when the time comes. But for these digital visits, this is just kind of a gift at this point. So just make sure your physicians are aware of that, just because I would hate to see them get used to getting reimbursed for something that may not happen in the future. And then one of my other questions I had has to do with the integumentary system. So here's one from one of my dermatology clients that are in Illinois. And they basically said, "Good morning, Terry. I have a question regarding procedure 11102, which is a shave biopsy, and ICD-10 code R21, which is a rash." She said, when reviewing for 11102 and Codify, which is their software, kind of like IntelliCode, the ICD-10 list for this procedure does not show R21 being listed as a payable diagnosis when billing for the shave biopsy. Is this correct? So it is correct, because remember, when you're trying to bill for a biopsy, a rash diagnosis is not going to be an option. There has to be some kind of lesion, wart, growth, polyp, etc., because you're taking something off and sending it to pathology. A rash won't cut it. So that is a correct basically edit, is so that that will back up against that code. So always kind of look at the reality of the procedure when they're linked to diagnoses, and just say, okay, does this make sense just from a common sense perspective? And then I think you definitely would probably be able to answer that question on your own. Okay, so let's take a look at a question that actually is a billing question and a denial question that you may not be aware of. So I've noticed that a lot of clients said that we recently got a Medicare claim denied for invalid patient information, and they don't know what's going on with that. So if you've ever gotten a claim denied for invalid patient information and you're positive that you submitted the correct Medicare beneficiary identifier, that's the MBI number, to the payer, you're not alone. If this happens, you should first verify the patient's name, spelling, and that's the patient's name and MBI match. Okay, start there. One way that this denial can happen is if the patient loses their Medicare card. In the past, they'd get a new card with the same ID number on it because that was their Social Security number and then the letter of the coverage that they had. Well, that's not the case anymore. The reason that Medicare revamped this system and started with the MBI numbers is because of identity theft and everything like that. So now what happens is that if the patient loses their card now, Medicare will send them a new card and they will reissue them a totally new MBI number on it. I don't know if you're aware of that. So another problem that can occur, or this happens because two of your patients may have the same name and your system may pull up the wrong MBI if you just input the patient's name into your system and you didn't identify with a correct middle name, middle initial, or information like that. So make sure you know their government issued name. You may call the patient by one name, but their official name may be something different. You can also use your Part B Max MBI lookup tool if you need to. If you have their name, their date of birth, and Social Security number, and customer service will protect patient information and will not release a patient's MBI to you if you call your Max. So you have to actually look up the lookup tool. And you can find that on any of the MAC carriers' website. So hopefully that was helpful as a billing question, because I didn't think maybe a lot of people realized that they are reissuing some numbers if patients lose their cards. And this is a great idea. You know, it's not just tied to that patient's social, which can be anywhere in their trash, from mail that they've opened, bank statements, etc. So, but it will mess you up from an accounting perspective if you weren't alerted that the patient just called and said, hey, can I get a new card? Sometimes the patients aren't aware that they're actually getting a new number as well, and they would have to let all of their providers know that. Our coding questions are brought to you today by Keck Medicine of USC. Over 500 nationally renowned doctors at a leading academic medical center, keeping you healthy, on track, and doing the things you love. The Keck Effect, keckmedicine.org. Okay, my personal tidbit this week. Well, we are off and running and planning my daughter's wedding, and we actually found a site. We have her gown that needs to just have some alterations, oh my gosh. And then she, of course, has picked out her honeymoon plan. Yeah. Hi, Mom, can I have this? She's so spoiled. And then she was able to, she just shows up. I get all this stuff ready for her, and she shows up and she's like, oh my gosh, I love this steak. I love this side dish. I love the look of things. She's got her own built-in wedding planner lives in California and she's in Arizona. It's crazy. But, you know, I'm having a pretty good time with it. I got one daughter, and it's pretty fun. I really kind of think there's times when she can be a little bridezilla, but overall we're having a great time with it. So anybody that wants to send me some support through the DMs you send me, I really appreciate those. Thank you. She's not getting married till March of next year, but I'm telling you, there's a lot to do until then, but it's pretty fun, and I love them as a couple, so it's all good. All right, everyone, that's it for me today. So make it a great rest of your week. Make it a great day, and thank you for listening to the CodeCast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.